Hello, my name is Dr. Stephanie Jones, and I will be discussing the other magnet in the OR, cardiac implantable device risks. This lecture is part of the FUSE, Fundamental Use of Surgical Energy curriculum. Hopefully this will give you a good taste of that curriculum and encourage you to pursue it further. Just a little hint, I have written the more difficult questions on the FUSE exams, so if you pay attention, it might help you score a couple points. I have no relevant disclosures. What sort of implantable devices exist in your patients that can be impacted by surgical energy? Certainly, cardiac implantable electronic devices, or CIEDs, are the most common, but there are a plethora of other various things that can exist. Stimulators for the deep brain, spinal cord, vagal nerve, and sacral nerves, implantable infusion pumps, and cochlear implants. So just something to keep in mind, although we won't be discussing those other devices today. When we talk about CIEDs, we're talking about pacemakers and implantable defibrillators. Most of the newer devices are actually very well shielded from the effects of surgical energy. However, devices can overcome this shielding, particularly when procedures are done in close proximity or with higher levels of energy. What's the extent of the problem? How many of these devices are floating around? One article estimates that there are at least 3 million patients with conventional pacemakers and about 750,000 devices implanted in the US yearly. The Heart Rhythm Society a few years ago estimated that 10,000 ICD implants were placed per month on top of the existing population of about 300,000, and that by this year, there would be about 670,000 implantable defibrillators around. What devices in the OR can cause electromagnetic interference? What we're mostly concerned about here are monopolar electrosurgical devices. However, think about if you're doing endoscopy. Advanced endoscopy, monopolar endoscopic devices exist as well. Radiofrequency ablation is a high energy monopolar device. And then you have other things around, things like electrocardiographic monitors, fluid and blood warmers, MRI and CT scanners, and nerve stimulators. What factors determine the effects of EMI on a CIED? Basically, this comes down to the intensity of the field or source, the frequency and waveform of the signal, the distance between the source and the CIED leads, and the orientation of leads with respect to the field or source. Essentially, in other words, what device are you using, what mode, what energy level, where did you put the dispersion pad, and what's the current path from the device to the dispersion pad. What are the potential effects of EMI on a CIED? The one that we're most concerned about is inappropriate inhibition or triggering of a pacemaker or defibrillator. So the device is seeing the electrical energy as a cardiac signal. If it's an ICD, it might interpret this as VFib and shock the patient. If it's a pacemaker, it may think that there is a native rhythm and stop pacing. More rare would be unintended asynchronous pacing as a response to noise. Even more rare would be reprogramming. This is much less common with recent models. However, resets and safety modes are possible. You can also have damage of the electrical components. It's unlikely that the pulse generator will be damaged unless the energy is very close to the generator or right on top of it. You can have the electrical energy conducted by the leads themselves, inducing VFib or AFib. And you could potentially have thermal injury at the lead tissue interface, resulting later in scarring and potentially rendering the existing pacemaker settings ineffective. What do you need to know preoperatively? First of all, does your patient have a device? Hopefully a history and physical will reveal this. Then you need to know what type. They might have an ID card, we hope. You could see it on a chest x-ray. You also need to know if the patient is pacing dependent if they have a pacemaker. Again, hopefully by history, but you can also have the pacemaker reprogrammed to a minimal rate and see if there's adequate ventricular activity behind that. And how's the device functioning? Has it been interrogated in the last 6 months to a year? Do you see spikes on an EKG if the patient is being continuously paced? Basically, what you need to do is get the information from the physician responsible for the management of that device. Essentially, get a prescription for what should be done with the device during the procedure. This is your best bet. Even more so with some of the novel devices that are not now around, which are less commonly seen and perhaps not necessarily handled in the same way. There's wireless pacing devices, leadless pacemakers, and sub-Q ICDs, and these are becoming a little more prevalent in the last couple of years, but still not nearly as common as the more standard devices. Then you need to decide that whether EMI is likely to occur. Can a bipolar or ultrasonic scalpel, something like a ligature or gyrus, be used instead of monopolar devices? If you need to use a monopolar device, then can unblended cut be used, which is better than blend and better than coag when it comes to interfering with CIED devices. Basically, when you're talking about the choice of mode, unblended cut is continuous, easier for the device to filter, and lower voltage, and that's the benefit of that device or that mode. The other question that always comes up is, should the pacemaker be reprogrammed to an asynchronous mode, right? So a DOO or a VOO mode. Most of the time, if the patient is pacemaker dependent and you're doing a procedure with a device that puts the patient at risk for interference, you probably want to reprogram that device. You do have to, however, beware of the potential for RNT phenomenon, where the pacemaker ends up giving an energy stimulus on top of a T wave, causing a ventricular tachycardia. Other modes exist. There are certain pacemakers that have rate adaptive functions. You'll see a letter R in the 4th place on the NBG code, so DOOR, for example. And these are mechanical or physiologic sensors that will increase the heart rate in response to, as a response to exercise. So that's great if your patient's exercising. It may not be a desirable increase in heart rate under anesthesia during a hemodynamically unstable situation, et cetera. So something else to keep in mind. Most of the time you do want to suspend the anti-tachyarrhythmia functions of ICDs, otherwise you're placing the patient at risk of an unwarranted shock. Anytime you start suspending functions, you want to make sure that you have defibrillation and temporary pacing equipment immediately available. The next question, should a magnet be used? Certainly it's simpler often than involving your cardiology team or an industry rep to reprogram the device. For a pacemaker, it often results in an asynchronous mode. However, this varies highly by manufacturer, and the exact mode may be affected by the remaining battery life. For ICD, very important to keep in mind that usually a magnet will not alter a pacing function. So if you have a combined pacemaker ICD, it will often disable the tachyarrhythmia therapy, but not affect the pacing function. There have been cases where the tachyarrhythmia therapy was permanently disabled. This is again rare and occurred quite some time ago, but just to keep in mind that anytime you're messing with these devices, there can be some unexpected sequelae. For monitoring, you want to always have a continuous EKG, that's ASA standards. And for some sort of perfusion monitor, so a pulse oximetry waveform, a plethysmograph, or an arterial waveform will show you that the patient is perfusing particularly when you're seeing EKG interference on your screen and are unable to determine whether it's real or an artifact from the electricity. So here you can see on the bottom line is an art line tracing, and on the top you can see, okay, that just maybe looks like some noise from the electrosurgical device, but in fact, it is inhibiting the pacemaker such that you have this nice 4 or 5 beat pause in perfusing rhythm. So the EKG is not reliable here, right? You really can't see whether the patient has a perfusing rhythm. In terms of monopolar devices, what are the tips to help minimize the effect of the device on your CIED? The first thing is to position the dispersion plate such that the current does not cross the CIED system. So depending on where your surgery is, the thigh may not be the right place. So if you're working on, let's say, the upper part of the chest, and you put the dispersion plate on the thigh, you're now crossing your leads with that current. You do want to keep as far away from the generator and leads as possible. Generally, it's felt that surgery below the umbilicus, so greater than 6 inches from the leads, is generally felt to be lower risk. The other thing to keep in mind when you're dealing with a magnet is the patient position. Does the patient position allow good contact of the magnet with the generator? Now, if one of the good things about having a magnet on for an ICD is that if they do need therapy, you can quickly take the device off. You're not having an ineffective device where you now have to externally shock the patient. This is, again, an illustration of how to hopefully avoid creating a problem with your surgical current. This is what not to do. Try not to have the current crossing your generator and your leads. Again, below the umbilicus is felt to be generally safe. And this was a more recent study that was done by Schulman et al., actually specifically addressing this umbilical question. And what they did was they had a very standardized placement of where the dispersion pad was. They did both cardiac and non-cardiac procedures. One of the big differences being the cardiac procedures had a full underbody dispersion pad versus the more standard sticky dispersion pad. And what this study does support is that you do want to suspend anti-tachyarrhythmia therapy when you're doing monopolar electrosurgery above the umbilicus. What they were able to show was that above the umbilicus in non-cardiac surgery, there was a 7% risk of clinically meaningful EMI. So not just anything, but something that actually caused pacing inhibition or an inappropriate shock. For cardiac surgery, that number was much higher at 29%. And this is a nice infographic that sums up that study. How else can you mitigate some of the risk? Don't arc when you're using your device. Use short intermittent bursts. As I said before, use cut preferentially over coag, and use the lowest feasible energy levels. And that last bullet really should apply to any time you're using an electrosurgical device. Also keep in mind radiofrequency ablation, if this is something you do, is very high energy monopolar device, okay? You want to, again, avoid contact between the pulse generator and the leads, keep the CIED out of the current path. You may tend to see even more devices in these patients because the whole reason they're having an RFA instead of surgery is that they have more comorbidities. You're also applying the energy for a much longer period of time than you would when using a tool in surgery, so it could potentially have a greater effect on your device. There have also been some case studies looking at other sources of EMI. This is the wand used to find marked or tagged sponges, and this was when it was held over the chest on a patient with a pacemaker. And again, you can see this beautiful pause in the A-line tracing as it affects the pacemaker. Post-operatively, you want to make sure to interrogate the device, particularly if you've done any reprogramming, or if you have a higher risk situation, such as somebody who's pacemaker dependent, some sort of hemodynamically challenging surgery, or you did some emergent surgery above the umbilicus and didn't have time to sort of find out the particulars of the device. You do have to keep in mind that if there's damage at the lead tissue interface, this may not be apparent for 24 to 48 hours. You want to make sure that the function's been restored. So the take-home messages here, again, does the patient have a CIED? If so, what are the specifics? Make sure you understand whether it's an ICD versus a pacemaker or both. For intra-op planning, do you absolutely need that monopolar electrosurgical device? Note where you feel the current path is going to travel and avoid having that travel across the device. And think about your choice of monopolar mode. So use the lowest energy possible, use a cut mode if possible. And post-op, plan to interrogate the device if at all possible. What this comes down to is communication and knowledge. The cardiology team needs to know the particulars of the surgery, and the perioperative team needs to know the particular of the patient's device and physiology. And overall, that was what will keep your patient safe.